Welcome to this presentation on drugs to treat insomnia. I hope you had a restful night and now you are having a great day. Here's the objective for this presentation: to be able to treat various causes of insomnia. And by the way, this is a picture of my granddaughter. Some medications that cause insomnia. I'm just going to go through a few of them. Caffeine is a central nervous stimulant with a half-life of approximately 5 hours. This means that food or beverages that contain caffeine should never be consumed within the 5 hours prior to going to bedtime in any patient with insomnia. Patients should be encouraged to eliminate or limit all daily caffeine intake, since individuals with insomnia tend to be particularly sensitive to caffeine, and its duration of action increases as the dose increases. Alcohol is a CNS depressant that may decrease sleep onset latency when consumed during the evening. However, it may also depress respiration, precipitate snoring and sleep apnea, potentiate other sedatives, suppress rapid eye movement sleep, REM sleep, and produce awakening with difficult returning to sleep. Obviously, alcohol may also be habit forming and requires dose escalation to achieve the same effect. Patients with insomnia should be discouraged from drinking more than 1 glass of wine with dinner. The U.S. Food and Drug Administration has approved pharmacologic therapy for short-term use, 4 to 5 weeks, and suggests that medications not be used for extended periods. If insomnia does not improve after 7 to 10 days of pharmacotherapy, the patient should further be evaluated. If you have to use drugs, use the lowest therapeutic dose, use for the shortest duration necessary, discontinue the medication gradually, be alert for rebound insomnia, and use agents with short half-lives to minimize daytime sedation. Unfortunately, drug treatment for insomnia is the most common treatment approach. It almost always leads to drowsiness the next day. Sedatives and hypnotics were not meant for chronic insomnia. They are really only effective for a short term, a couple of weeks, of insomnia. Long-term drug therapy may be indicated when insomnia is severe or has not responded adequately to non-drug therapies, or when there is a chronic coexisting illness. Tolerance and dependency may develop, and withdrawal, rebound, and relapse of insomnia may occur. But sedatives and hypnotics are commonly used despite all of the above. 5 to 10% of adults have used a benzodiazepine in the past year as a sleep aid. 10 to 20% of those over age 65 use sleeping pills. These are all commonly used, but only the classes indicated are approved by the FDA for insomnia. Benzodiazepines work through the modulation of the GABA, I'm not going to spell that all out, of the GABA A receptor in neurons, resulting in hyperpolarization of the cell. GABA serves as an inhibitory neurotransmitter in the central nervous system, decreasing neuronal excitability. Through stimulation of GABA receptors, benzodiazepines cause sedation, decrease anxiety, muscle relaxation, and retrograde amnesia. Non-benzodiazepines sometimes referred to colloquially as the Z drugs, are a class of psychoactive drugs that are very benzodiazepine-like in nature. Non-benzodiazepine pharmacodynamics are almost entirely the same as benzodiazepine drugs and therefore employ similar benefits, side effects, and risks. However, non-benzodiazepines have dissimilar or entirely different chemical structures and are therefore unrelated to benzodiazepines on a molecular level. Here are the FDA-approved hypnotics for insomnia. The drugs are divided according to their indication for sleep onset, sleep maintenance, sleep onset and maintenance, and middle-of-the-night awakenings. I would print this slide for your clinical use. Just a couple others that I wanted to point out other than the benzodiazepines and the Z drugs. I wanted to point out Rameltian. It's a melatonin agonist approved by the FDA for insomnia related to sleep latency. Effectiveness is modest. It has a few adverse effects and is not habit-forming. Some people use tricyclic antidepressants, and doxapen is very favorable to use in adults for sleep. And other tricyclics such as amitriptyline and nortriptyline should only be used with insomnia with a comorbid depression, fibromyalgia, or some other neuropathic pain. But doxapen is good, especially for elderly. These are the 5 benzodiazepines that are approved for insomnia. Benzodiazepines do enhance sleep, decrease anxiety, and relax muscles. But when benzodiazepines are discontinued, the patient develops rebound insomnia, return of original symptoms, and withdrawal symptoms that were not present prior to treatment. Benzodiazepines cause daytime sedation and decreased reaction time. This, in turn, leads to cognitive impairment and memory problems. The unsteadiness of gait can lead to ataxia and falls. There is a risk of developing tolerance and a risk of withdrawal. We've already discussed that. They are a controlled substance and therefore possess a risk for abuse. Just to add to this, the risk of overdose deaths from opioids is 2 to 10 times higher when combined with benzodiazepines. The most commonly prescribed class of medication for insomnia is the so-called Z drugs. The Zolpidem, Zolpidem, and isoprolol. The Z drugs bind more selectively to subunits of the GABA receptor, primarily targeting the sedative effect of the receptor rather than the anxiolytic effect. Like benzodiazepines, the Z drugs have several adverse effects, particularly in higher doses, including memory loss, dizziness, disinhibition, GI upset, and hallucinations. Read over each of these drugs. Overall, the Z drugs have a lower risk of dependence than benzodiazepines. All of the non-benzodiazepine hypnotics listed here have a delayed onset if taken with or immediately after a meal. Zolpidem ER is not limited to short-term use, although no comparative trials have shown distinct clinical advantage of controlled release zolpidem versus immediate release zolpidem. So as a prescriber, you must be aware of the abuse potential of the Z drugs because they may cause stimulation, euphoria, anxiolysis in some patients, particularly at high doses. Azopiclone is a drug that has been used to improve sleep latency, and it is particularly well suited for sleep maintenance, given its long half-life. One unique adverse effect of azopiclone is unpleasant metallic taste that affects nearly 1/3 of patients at the maximum recommended doses. Ramelteon is a selective antagonist at the MT1 and MT2 melatonin receptors. It's the only medication FDA approved for insomnia that is not a controlled substance because it does not seem to lead to abuse or withdrawal. The non-benzodiazepines bind to subtypes of GABA receptors that specifically modulate sleep, and therefore these drugs are thought to have less unwanted side effects. Tolerance and abuse have not been shown to be a major problem in the general population with the non-benzodiazepines. In general, they have a shorter duration of action than most benzodiazepines and therefore are less likely to cause daytime sedation. Okay, now we are on to the over-the-counter antihistamines as sedative hypnotics. The main drug used is diphenhydramine, and it's usually compounded with either acetaminophen or ibuprofen. Chronic use of this leads to rapid tolerance. They have a half-life of 8 hours with residual effects of delirium, dry mouth, constipation, blurred vision, and urinary retention. It can also exacerbate narrow-angle glaucoma, and paradoxical reactions are possible where it is activating rather than sedating. You especially see that in children when you give them diphenhydramine. Some antidepressants are used for insomnia but are not FDA approved for this use. When these are used, they are at a much lower dose than for depression. Trazodone can cause priapism, even at low doses. Priapism is a persistent and painful erection of the penis. I really can't see any advantage in using these off-label for insomnia. As pointed out earlier, many opioid-related deaths have more than one controlled substance in the blood at the time of death, including benzodiazepines. Just look at this lethal cocktail taken by Heath Ledger. Some key clinical considerations. In the immediate short term, like the first week, insomnia or anti-insomnia medications can produce improvement at a much greater rate than non-medication treatments. But in the intermediate term, a meta-analysis indicates that behavioral treatment for insomnia is just as effective as medication treatment. Over the long term, patients receiving non-pharmacological therapies enjoy long-lasting relief, while many of those treated with medication return to their baseline insomnia levels.
Thank you for your...
There are two pathways for treating insomnia: medications and cognitive behavioral therapy. All treatments have their pluses and minuses. You need to look at the patient's impairment and weigh that against the risk of treatment. Many of the most common drugs for insomnia are not FDA approved for that purpose. No drug for insomnia is completely safe or free of the risk of side effects. And make sure you know what your patients are taking, including any over-the-counter medications and herbal medications. Chronic insomnia guidelines recommend behavioral therapy, including sleep hygiene methods and stimulus control before starting drug therapy. Now, I don't know how well this really works with patients when they come in and they want a sleeping pill and you give them a list of things to do instead. Prescription medications can be used appropriately for short-term and in selected patients long-term treatment. Drug therapy should ideally be limited to 4 to 5 weeks while patients are learning cognitive behavioral skills. Now looking at Z drugs, caution is warranted before Z drugs are used in the elderly as it increases the risk of falls. Doses should be reduced. Z drugs should be avoided in patients with established respiratory depression or other forms of respiratory compromise. Side effects of Z drugs are increased when taken with other sedating drugs, alcohol, antihistamines, benzodiazepines. CYP450 inhibitors, such as macrolides, increase the sedative effect of Z drugs. And CYP450 inducers, such as fentanyl, diminish their sedative effect. Again, Z drugs should only be used for short-term treatment, around the 4-week mark. Longer use is associated with dependence.
Thank you for your time and attention.